All right, so horizons of diagnosis and treatment with PSMA PET MRI. I wanted to call this future directions, but realized David had patents on that already. I would have owed him all sorts of royalties, so I stuck with the term horizons. Um, so I'd say a couple of years ago, everybody that showed up to see me with a new diagnosis of prostate cancer had an MRI with them already. And now I'd say probably 50 or 60% of patients that are coming to see me for initial consultation have a PSMA PET CT already. But every once in a while, I'll have a guy come in and see me that has had nothing done, just has a diagnosis of prostate cancer based on a biopsy alone. And there's things in medicine that just make no sense at all, or at least with how we order things. And that is I can go ahead and I can order an MRI of the pelvis for him. I can order a PSMA PET CT, but I cannot order a PSMA PET MRI for that patient and have it actually get approved. So I've got to expose them to additional radiation that I really get no additional use from. And I don't have a great way of kind of fusing those two images. If I just had, I could do it cognitively, but we don't have a more precise way of actually fusing the MRI with this PSMA PET MRI. Now, at our institution now, we do have the availability of PSMA PET MRI through our research imaging core, which is pretty nice, and we get beautiful images like this. But right now, we're using it in that occasional patient that hasn't had the MRI already for local disease assessment, not really using it so much for the evaluation of metastatic disease yet. And again, I really love this study, but it's very hard to get it approved. And because so many patients have had the MRI already, it's a little bit of a challenge. Now, what's the future of this? Because I think this does have tremendous potential to be doing PET MRIs instead of PET CT scans. Is there some opportunity with diagnosis, with further local disease evaluation for treatment decision making? Dr. Ryder very nicely showed how this is an additional prognostic biomarker. Can we use that for evaluation of metastatic disease? The effective therapy, which I hope we'll talk about as future directions. And can we use it as a biomarker of cure for early detection of persistent or recurrent disease in patients that, for instance, had focal therapy? And then is there some opportunity for what I call post-scan fusion? So this is the patient that came in with the MRI. I don't really want a PSMA PET CT, but I want a PSMA PET for that patient. And then I want to post hoc fuse that with the MRI that they've already had. And so is there some opportunity there? This is our research imaging core. So when I want to get one of these, this is where I send the patients. It's actually fairly easy to park there, which is a difficulty where we're at, but they have a nice waiting room. They get treated very nicely. There's almost concierge service. They have a nice PET MR scanner with simultaneous acquisition of data, which I think for PSMA PET isn't totally necessary. I understand if you're doing this for brain MRIs where there's temporally things that have some temporal association and you're trying to do that, but for PSMA PET MRI, it's nice to do them together, but I don't think it has to happen. Okay, so getting into diagnosis, Dr. Ryder talked about the primary trial, which is a very nice study that looked at a couple of hundred patients, or almost 300 patients. These patients were eligible if they had an abnormal PSA or digirectal exam. So this was basically looking at this as a screening trial, multiparametric MRI, and then they had a pelvic-only PSMA PET CT. And I'm not sure about the science of that, is if they had some other fusion software, if this was just cognitive fusion, what they did. But they generated these receiver-operator curves to determine the SUV max cutoff values. And it was a PSMA plus the MRI was considered positive. Either imaging was positive. The patients had transperineal biopsy, and then any Gleason or grade group 2 or higher was considered clinically significant. And the negative predictive value was 91%. But the specificity did go down, which is one of the things you have to be a little bit careful about as you're doing more studies. So the specificity was 40%. However, when you looked at the specificity of patients with high SUV max, so if it was a PSMA that had an SUV max of 12 or greater, all of them had clinically significant prostate cancer regardless of MRI results. And if you looked at patients with PIRADS 4 or greater lesions on MRI and an SUV max of 9 or greater, all of those patients had clinically significant prostate cancer. So the specificity can be very good when we're thinking about using this as a screening tool. Now, and this alludes to primary too, which I'll talk about in a minute, but there was still a significant number of patients that had 28% with PIRADS 2, which is pretty high, I would say, compared to other studies, and then almost 50% with PIRADS 3. So, they're going to explore this a little bit further, but those are patients, PIRES-2, I generally would not be biopsying, but with the 28% clinically significant prostate cancer rate, I would be thinking about it in that patients. And then going a step further, there are studies, and this study got a lot of interest in doing radical prostatectomy without doing a biopsy first. So these patients had robotic prostatectomy after they were determined to be high risk for prostate cancer from only a multiparametric MRI and a PSMA PET. All these patients had PIREDS 4 or greater. They had a PET score of greater than 4 on a 5-point Likert scale. The SUV max for those patients was around 6.5. And all these patients did have prostate cancer on final pathology. Similarly, this was done in China. I think you could do this in Germany and China. I would never do this in the United States, but the idea that we might be able to do a biopsy or have a biopsy-free radical prostatectomy is certainly an interesting thing to think about. So moving on that a little bit further is if we can avoid biopsy in some men, that does avoid some of the costs, of course, the complications, the discomfort. This would be very popular, I think, for our patients if we could just look at the imaging and then proceed directly with more treatment. And then I do think that the fact that this has very high specificity with PIREDS 4 or 5 lesions and high SUV, this is something that we could be using as the initial workup for a patient with an elevated PSA like they did in the primary trial, although we're not quite there yet. What would be more cost effective, however, I think, with this idea of potential future fusion or reflex imaging is that you do a biparametric MRI first, and then you reflex to the pelvis with a pelvis-only PSMA PET if they have specific findings. So you get a PIREDS 4 or 5, we're going to be taking that patient for a biopsy regardless. But if they have PIREDS 2 or 3, those are patients where I think we have more opportunity where they could get a pelvic-only PSMA PET, and then we could distinguish whether that patient needs a biopsy or not. And that's the focus of the primary 2 trial. Now, moving on to think of this as a prognostic biomarker, there's still a lot of science that needs to be determined around what the best parameter might be. And this study looked at different things like SUV max, total lesion uptake, tumor volume, other characteristics that they could get from a PSMA PET scan that might be useful. It is linked in several stages of disease, so not just localized disease, but also in patient with metastatic disease. And then, of course, it's a predictive biomarker in the sense that we're determining treatment based on positivity to a PSMA PET CT scan. And that's been used for some time now. A couple of studies that are out there. Can we use PSMA PET MRI to guide and monitor therapy? The Canadians are a little ahead of us here, but for patients they're enrolling them into the Argos Climber trial, which is SBRT. They're going to get a PSMA PET MRI prior, and I think these are still separated studies, not concurrent PSMA PET MRI, but using it pre, and then they're going to do scanning afterwards. And there's going to be a similar study in Alberta. So this one, they're going to use the PSMA PET to determine candidacy for focal ablation, and then they're going to repeat imaging 12 months after treatment, and a similar type of thing where they're doing dose escalation in patients with PSMA PET MRI-based to do the hypofocal SBRT trial, using that in patients that are having SBRT. So I guess I'll ask Phil this question, why can't we have the science, have this where we can fuse and have a patient that walks in with an MRI, get a PSMA PET, and then somehow fuse those? This seems like it's a math problem that's already been solved. If we can have some fiducials in a patient where we can just kind of overlay those things and then have a better study. Of course, we won't be always getting imaging outside the pelvis, but that's less relevant in these patients, of course. So the best patient for a PSMA PET MRI, currently we're only using this for higher unfavorable intermediate risk disease, and they've had no prior MRI or a PET CT if we can get it authorized. But in the future, I do think these are great tests for assessing patients for focal therapy, whether that's a good treatment for them or not, and then also use that post-treatment to determine whether the disease may be cured, or to use this as a long-term follow-up for these patients. So thanks for that, and we'll give time back now.